Thank you for joining us this afternoon to discuss the 3-day, 1-day payment window. My name is Karen Curtis, and I'm a Provider Outreach and Education Specialist with WPS Government Health Administrators. Today I'm joined by Tom Ryan. He will be providing all of you with some additional information as well as monitoring the chat for questions. The 3-day, 1-day payment window has been a suggested topic on surveys that we've received. This has also been a topic that has been looked at by the Office of Inspector General because of the millions of dollars that has been spent in overpayments. Today's webinar is an overview, and I do plan on having future events where we can discuss more of the billing requirements in more detail. This next slide is our disclaimer. We do our best to provide the most current, accurate information, but as we all know, Medicare rules can change often. The information I am presenting is accurate as of today, but the CMS website should be checked often for updates. CMS prohibits recording of this webinar for profit-making purpose, so we ask that you don't record the presentation. This event is being recorded and will be posted to the WPS GHA website on the Encore presentation webpage, as well as our YouTube channel. This afternoon, I'm going to define the 3-day, 1-day payment rule. We'll talk about which providers are affected and how to apply the rule when submitting claims. I've provided a list of acronyms, so if you find that I use one in my presentation that maybe you're not familiar with, you can reference back to this slide. Let's start off with defining the 3-day, 1-day payment rule. Medicare's 3-day or 1-day payment window applies to outpatient services furnished by hospitals and hospitals wholly owned or wholly operated Part B entities. The statute requires that hospitals bundle the technical component of all outpatient diagnostic services and related non-diagnostic services with the claim for an inpatient stay when the services are finished to a Medicare beneficiary in the 3 days preceding an inpatient admission. For hospitals that are excluded from IPPS, this rule applies to services received 1 day prior to admission. And hospitals excluded from IPPS, it could be hospitals or units that would be a psychiatric or inpatient rehabilitation facilities or units, long-term care hospitals, and also children's and cancer hospitals are sometimes exempt from IPPS. When you are calculating the payment window span, you are going to use calendar days and not hours. There could be times where people talk about the 72-hour rule, but 3 calendar days could be more. So you'll want to make sure that you're using calendar days and not hours. There are certain exclusions to this rule. Part A services that are provided by a skilled nursing facility, a home health agency, or hospice would not need to be included on the hospice. Sorry, just okay. Let's see. Okay. Tom, can you hear me?
I can hear you now, but you were breaking up for just a bit there, but I can hear you now.
Okay, and my presentation showing because it went blank for a minute.
Your presentation is showing general guidelines for me. It said excluded Part A services.
Okay, sorry everybody. I'm not exactly sure what happened, but so certain exclusions do apply to this rule. Part A services provided by a skilled nursing facility, a home health agency, or hospice would not need to be included on the hospital's claim. Ambulance transportation and maintenance renal dialysis services would also be billed separately. And if the beneficiary does not have Part A Medicare, services that are received prior to the point of formal inpatient admission may be billed separately. Services which would always be included on the inpatient claim would include outpatient services provided on the day of admission. CMS has stated that services other than ambulance and maintenance renal dialysis that are provided on the day of admission are deemed to be related to the admission and must be on the inpatient claim. Diagnostic services and non-diagnostic services related to the inpatient admission must be included provided they are within the payment window. And before we get into the details of applying the 3-day, 1-day rule, we're going to talk a little about the providers that are affected. So what does it mean to be wholly owned and operated? Wholly owned refers to a hospital other than the admitting hospital or a Part B entity for which the admitting hospital itself is the sole owner. So when I talk about a Part B entity, I'm referring to like a physician's office or a clinic, independent diagnostic testing services, freestanding radiology oncology centers, and ambulatory surgical centers. So a hospital or a Part B entity that is wholly operated by the admitting hospital means that the admitting hospital has exclusive responsibility for conducting and overseeing routine day-to-day operations. The admitting hospital does not have to have policy-making authority in order to be the sole operator. Now, to add another layer to what can already be a confusing situation, if a third organization, such as a health system, owns and operates both the admitting hospital and the Part B entity, then the payment window does not apply. So because there are so many possible business and financial arrangements that can occur between hospitals and Part B entities, CMS and MACs are not able to provide any assistance when it comes to making this distinction. The hospital and the Part B entity are responsible for coming to a consensus as to whether their relationship meets the definition of wholly owned or operated. Some examples that could help to determine if you are wholly operated by the admitting hospital would be if the admitting hospital provides management services to your facility, or if they have control over areas that are critical to running the day-to-day operations, such as decisions regarding executive staff, medical staff appointments, and admission policies. If the admitting hospital's name is included in the Part B entity, that would be a sign that you'd be wholly owned or operated. If the Part B entity's leadership reports directly to the hospital's management or their senior administrators. Other examples would include if a Part B entity's costs are included in the hospital's Medicare cost report, or if the facilities have overlapping boards. In the end, the responsibility lies on the hospital and the Part B entity. So they would need to determine their relationship and see if this rule would apply. So we're going to move on to some guidelines to help you determine when services would be included or excluded from the payment window rule. One question you may be asking is, how am I going to know when the beneficiary has been admitted to a hospital? It is the responsibility of the admitting hospital to notify any wholly owned or operated entities if a Medicare beneficiary who has received services has been admitted. So if you're one of those Part B entities, you should be getting notified. We're going to start out with talking about diagnostic services. So a diagnostic service consists of an examination or a procedure that will allow healthcare providers to assess a patient's medical condition or identify a disease. These services can also be used to determine the nature or severity of an injury. Some examples would include diagnostic laboratory, diagnostic x-rays, isotope studies, EKGs, thyroid function tests, and psychological tests. Non-diagnostic or therapeutic services help physicians or practitioners treat their patients. These services can include emergency room services, observation services, and procedures that are performed to treat the beneficiary's illness or injury. Related non-diagnostic services would be services that are clinically related to the inpatient admission. Now, the diagnosis code does not need to match for the service that is in order for it to be considered related. That was a rule that changed with the Preservation of Access to Care for Medicare Beneficiaries and Pension Relief Act of 2010. And what this act did was that it expanded the definition of related to so that the diagnosis codes were no longer a defining factor. Unrelated non-diagnostic services are deemed to be clinically unrelated to the inpatient admission. And if a service is determined to be unrelated, you will definitely want to make sure that this is documented. CMS has not provided a defined list of what is considered related non-diagnostic services. They believe that this decision has to be done on a case-by-case basis and that it requires knowledge of the specific circumstances surrounding the patient's admission. So for this reason, CMS has left it up to the admitting hospital to determine if an outpatient service is clinically related to the inpatient admission. When should diagnostic services be included on the inpatient claim? If those services were provided by the inpatient hospital or an entity that is wholly owned or operated by the admitting hospital, they would need to be included. Critical access hospitals would need to include their service only if they are wholly owned or operated by a non-critical access hospital. If you are a physician's clinic or practice that is wholly owned or operated by the admitting hospital, then services within the payment window would need to be included on the inpatient bill. So for excluded diagnostic services, a critical access hospital and those critical access hospitals that are wholly owned and operated by another critical access hospital do not need to include their diagnostic services on the inpatient claim. The 3-day, 1-day rule also does not apply to services provided in an RHC or an FQHC if they are included in the all-inclusive rate. Services provided prior to the payment window span would be billed separately, and this would include services that were part of a continuous outpatient encounter. So one of the pre-submitted questions that I received asked about a patient who was in observation for 3 or more days prior to an inpatient admission. And they asked, would Medicare require 2 separate bills? So the answer is yes. Depending on the type of hospital or unit, the outpatient diagnostic services provided outside of that 3-day or 1-day payment window would be billed separately. So if a patient's in observation for 4 days, let's say, only the services that were on those 3 days prior to the admission would be included. That day that goes outside of that range, that can be billed separately. Next, we'll move on to included non-diagnostic services. Non-diagnostic services that are related to the inpatient admission will need to be included on the inpatient claim. So in the past, if you've been in Medicare for a while, it used to be that when you submitted a claim, the system would look at the primary diagnosis codes. And if the primary diagnosis codes matched, then the Part B claim would get rejected. Now that that's done away with and everything's been broadened to encompass pretty much any non-diagnostic service, unless you are told it's not related, the diagnosis codes aren't that important anymore. So who determines if the service is related? Like I said, that would be the admitting hospital. So as a facility who provided outpatient services, you will want to be sure that whatever decision the admitting hospital makes, that you have that documented. You know, if they tell you that it's not related to the inpatient admission and that you can bill that separately, you're going to want to make sure you have that somewhere in case, you know, a claim would get rejected or denied, and you'll have backup. Like I said, this webinar isn't an introduction, so getting into the nitty-gritty of how to build that claim and what codes to put on it to show that it's not related, we will get into that at a later date. Critical access hospitals that are wholly owned or operated by the admitting hospital must include their related services on the inpatient claim. The technical portion of services related to the inpatient admission performed during the payment window are considered hospital cost and should be included on the hospital claim. And any services provided on the day the patient is admitted is going to be considered related and should be included on that inpatient claim. So as far as excluding non-diagnostic services, those are going to be services that the admitting hospital has deemed are not clinically related to the patient's admission. Services provided to a beneficiary by a CA or an entity that is wholly owned or operated by a CA would not need to be bundled into the hospital claim. This rule also applies to non-diagnostic services included in the all-inclusive rate for RHCs and FQHCs. And as the same with diagnostic services, anything that is outside that payment window would be billed separately, even if it is all on a single outpatient encounter that spanned multiple days. Here I've provided some resources in case anybody wants to go out there and see if they can find additional information. And before I ask Tom if there's any questions, I'd like to cover a couple of the pre-submitted questions that I received. The last time that I checked was yesterday afternoon, so if you were someone that could have possibly registered after that and you entered a question, I probably did not see it, so I apologize for that. I did have people ask about correct billing practices, claim errors, and how to handle denials. So that is something that I will start working on for future webinars. one of the questions that I received had to do with a patient who is an inpatient in the hospital and they get discharged and then they're readmitted within 3 days of discharge. Now, this relates a little more to repeat admissions or interrupted stays, and there's a lot of factors that could influence the answer to this question. Like, for the person that asked the question, I don't know what type of facility they are. I don't know if the second admission was related to the first. So I'd really need more information before I could provide an accurate answer for that. I'm not sure if that person is on today, but I just wanted to put that out there so that they knew. Another question I received was a little more specific. This person stated, CART is a life-saving treatment that can be done outpatient, but the 3-day window rule makes providers reluctant to pursue this because the payment model drastically changes the reimbursement. Is there any way to overcome this? Now, I do not have any medical training, but when I looked up what the CAR T-cell therapy was, it seemed to me that this would be considered non-diagnostic because it's used to treat a patient who's already been diagnosed with cancer. So with that being said, it's going to depend on what the patient is being admitted to the hospital for. So it would depend on if it's related to the inpatient stay. And the bottom line is that the hospital or the facility where the services were performed, if they are wholly owned and operated by the admitting hospital, then the admitting hospital would have the final decision as to whether or not that those T-cell therapy, whether it's related or not. So I'm going to move over to Tom now and ask if we have any questions.
Hi, Karen. We do not have any questions in the chat. So again, if you guys do have a question and you'd like us to have the opportunity to answer that for you, go ahead and put that in the chat. Also, clarification on the question that Karen asked on would be great too. But we don't have anything currently in the chat.
Okay. Then I will go ahead and move on. I want to thank you for joining us today. Be sure to keep an eye on our live events page for upcoming webinars. And since we will have future webinars on this topic, please let me know if there's something specific that you would like to see me cover. These topics can be submitted to our education mailbox the same way that you would send in a follow-up question, and those will get sent to me, and I can make sure that it's included. On behalf of Provider Outreach and Education, thank you for your participation today. We look forward to your survey comments and hope that you join us for future events.